All right, so I am Justin Palmer. I had the pleasure of working under Dr. Serene Haydar this summer in the pharmacy, investigating the relationship between a gene called UGT1A1 and the toxicities of irinotecan during a 5-day regimen. Before we start, though, I just want to introduce myself. I am born and raised from Chicago. A lot of people, being from a big city, ask me if I'm from like Chicago proper or just from the suburbs. So I actually grew up on the very edge of Chicago in a town called Oak Lawn. It's like 3 miles from the edge, so I do claim Chicago still. But I graduated from Illinois State University in 2023 with my bachelor's in biology, and I'm about to start my second year of pharmacy school at the University of Michigan College of Pharmacy. In terms of after pharmacy school, I'm looking into completing residency to become a clinical pharmacist. That's something I've gained a lot of interest in, especially after this summer. And some fun facts about me: during my grad, I got to study abroad in Australia and Gold Coast. I minored in film studies, and I researched bumblebees in my undergrad, which is nothing what I'm going to talk about today. So for my project, I had to learn a ton about pharmacogenomics, and I think the best way to learn about it is with a scenario. So let's say all these people in the blue here get the same diagnosis, they all get prescribed the same drug, and they all take it the same way. Ideally, we'd expect everyone to get the same response with minimal toxicities. However, in reality, we know that everyone experiences medicine differently. So some people might get severe side effects, such as like stomach cramps, and then other people might not experience side effects, but they might not get the desired result anyway. So with pharmacogenomics, we can account for this difference with genetics. So we can use a patient's genetic information to determine a genotype for a specific gene, and then based on their phenotype, give a clinical recommendation for that specific drug. So here at St. Jude, when consulting patients, we like to use a speedometer to kind of visualize where they're at in terms of enzyme function. So if your genotype correlates with decreased enzyme activity, you'd be placed in this poor metabolizer category, and then we could give a therapeutic recommendation depending on the drug. And some examples of the recommendations we make are like lowering the dose, increasing the dose, or recommending a different medication. So you might think that these variants and these recommendations are rare, but patients at St. Jude are actually lucky to get pharmacogenomic testing done every time they come here. Or not every time they come here, but every patient gets testing through the PG for Kids clinical trial, where we test for 16 pharmacogenomic test results. 95% of patients carry at least one high-risk phenotype for those 16 genes. So this small portion right here, this 5% in the red, is our patients that have normal metabolizer status for all 16 genes. So clearly there's a need to be genotyping patients, especially high-risk patients that undergo toxic therapy and or long-term therapy, like our pediatric oncology patients. One of the genes we test for is called UGT1A1, which codes for the enzyme by the same name, UGT1A1. UGT just stands for uridine diphosphate glucuronyl transferase, and all that means is that it transfers glucuronide. It's normally responsible for conjugating bilirubin, so it transfers that glucuronide onto bilirubin, and the reason we test for it is because it's polymorphic. So certain variants are actually correlated with conditions of elevated bilirubin due to decreased function. Now, these polymorphisms also have implications for drugs. These are a few listed, but the main two that have pharmacogenomic recommendations for them are atazanavir and irinotecan. And irinotecan is the drug that my project focused on. Irinotecan is a common chemotherapy agent used for solid tumors. It is a prodrug, which means that it needs to be activated by something in the body. So in this case, it's activated by carboxylesterases, breaks off this group, and it becomes the active agent called SN38. SN38 is the molecule that inhibits topoisomerase 1, and that disrupts DNA replication, causing cell death. It can be administered both orally and intravenously. So because it acts on DNA replication, it primarily affects rapidly dividing cells. So that's how it causes myelosuppression, because some of it can get into the bone marrow. The white blood cells are rapidly dividing, so that's how it causes myelosuppression, but it's also notorious for causing diarrhea, which is where it gets its nickname, I ran to the can. So if you think about our favorite fast food place, Taco Bell. You can maybe make connection. So to put it all back together, bringing UGT 181 back into the picture, say you're administered irinotecan, gets in your blood, and carboxylases are everywhere, but it gets activated into SN38, and then everything in the blood goes to the liver. UGT1 is located in the liver, and it conjugates SN38 to deactivate it. If you're a poor metabolizer for UGT1A1, you have decreased enzyme function in UGT1A1. So you'll get less deactivation of the active agent, leading to a buildup of that active agent. The longer that SN38 is in the body, so the more there is, the more increased risk for those toxicities that I mentioned. Now, normally in adults, irinotecan is given as a one-time dose of 350 milligrams per meter squared intravenously per course. And for poor metabolizers, it's recommended by clinical researchers to reduce that dose by 30%. And we do that because many studies have verified that the poor metabolizer phenotype is correlated with increased toxicity from irinotecan. So this figure shows ANC nadir in the y-axis, and that just means the lowest count for the absolute neutrophil count during that course, and then the genotypes on the bottom. So on the left is normal metabolizer, the middle is intermediate metabolizer, and the right is poor metabolizer. You can see that the poor metabolizers experience significantly lower lows or lower nadirs than the other two groups. And this trend correlates to increased neutropenia occurrence. Now, this dose reduction is used in terms of patients receiving standard dosing regimens, but not for fractionated regimens. And fractionated regimens are commonly used in pediatrics. And they're used because they're associated with decreased myelosuppression. For this 5-day regimen that we use in pediatrics, there's a scarcity of data on the occurrence of side effects between UGT1A1 phenotypes. So we don't know if that correlation that I showed before is the same in this dosing regimen. So for my project, we asked, is there an association between the UGT1A1 phenotypes and the toxicities we see when patients are receiving this 5-day regimen? And to answer this, we looked at diarrhea occurrence, diarrhea severity, and neutropenia occurrence. To see if there was an association, we conducted a retrospective observational study of all patients between August 2013 and September 2022 that had a UGT1A1 genotype in their chart and had received IV irinotecan for 5 days at 50 milligrams per meter squared per day. This, I should have explained before, the per meter squared is just another way to dose medications. Instead of like body weight, it uses body surface area. The best way to collect the data was with manual chart review, where I looked through various documents looking for specific reports of diarrhea and reports of diarrhea management. Then I used lab documents to track white blood cell counts, absolute neutrophil counts, and I also kept track of admissions for febrile neutropenia. Now, I started with a big list of 1,388 courses of patients who had received irinotecan and had a UGT1A1 genotype, but I had to exclude 685 courses for the reasons listed, and that left me with 703 courses to review. Looking at that list, I found that there was a couple patients that had indeterminate UGT1A1 phenotypes, and that just meant that they had a genotype that didn't fit into one of the categories listed, so I had to exclude them, and that left me with 690 courses to evaluate between 128 unique patients. From those 128 patients, I've only gone through 101. The median age for those patients is 12 and a half years old. A majority were male, majority were white, and about 15% were Hispanic. The main thing I want to point out is the distribution we see between the UGT1A1 phenotypes, normal on the top, intermediate middle, poor on the bottom. Those are consistent with the distributions we see in broader communities. And I also kept track of diagnoses for those 101 patients. The most prevalent diagnosis was rhabdomyosarcoma. That's a common indication for irinotecan. From the 101 patients I made it through, I reviewed a total of 577 courses, 509 of which were from intermediate or normal metabolizers, while 68 were from poor metabolizers. The blue on the top part of the bar shows courses that had reports of diarrhea versus the bottom courses with no reports of diarrhea. As you can see, there's no difference between normal and intermediate metabolizers versus poor metabolizers in the occurrence of diarrhea. And for diarrhea severity, we found the same. So for qualifying the severity of diarrhea, we used the use of IV fluids, specifically for treating diarrhea, as an indicator of severe diarrhea. And that was based off previous work by pharmacists here at St. Jude. The blue, again on the top part, shows courses that had reports of IV fluids used for diarrhea. And as you can see, there's no difference between normal and intermediate metabolizers and poor metabolizers in the severity of diarrhea. This data I'm showing you, however, is still preliminary, so we are still working on analyzing more data points, including neutropenia occurrence, before we start making conclusions, although we have ideas on why this trend is occurring. In terms of the limitations, this was a retrospective chart review, and a consistent issue I came across was tracking diarrhea in courses and the use of antidiarrheal agents. And this was mostly because this relies on both the patient to report their use and report diarrhea, as well as the provider to record it in notes. Another limitation was multiple confounding factors for diarrhea, such as GI infections, compliance issues with antidiarrheal regimens, and concomitant drugs, because irinotecan is usually not given alone. Looking ahead, like I said before, that was preliminary data, and also I didn't get through all the patients, so we still have to finish the rest of the data collection and analysis. With that, I'd like to thank the St. Jude patients and families for allowing us the chance to learn from them, and the various people in the pharmacy department, particularly Dr. Serene Haydar, my awesome mentor and teacher this summer, Dr. Christine Cruz, who helped me organize this project in the very beginning, Dr. Catherine Robinson, who helped me learn R and put together my data, Dr. Megan McNulty, who is the past PGY2 resident that had the pleasure of answering my questions all day and every day, and then Dr. Joshua Geary, the current PGY2 resident, who also answers my questions all day and every day. Also, big thank you to the Pediatric Oncology Education Program and Dr. Gronemeyer. This was one of the best summers I've had, so thank you. And also thank you for my family for their support, especially my dogs. With that, I'll open the floor to any questions.
It looks like you had good work. It was a nice study, sorry. Looks like you have about 50-50 for male and female. Do you think that there will be any sex differences? Do you plan on analyzing or reanalyzing your data to look at any sex differences?
What kind of differences?
So if you separate your right now you're looking at all 101, right? And you've got 53 or 4 that are male and 40 whatever. I can't do. But if you take that apart and then just look at the males and just look at the females to see if there's actually any.
Oh, you said sex differences.
Yeah.
Sorry, I misunderstood.
Oh, okay.
I don't think so. I wouldn't expect there to be any difference, and I was told that it's actually expected. Majority of majority of oncology patients are male, and so that finding kind of showed us that our data was the data that we pulled is a good set. But I don't think we'll be analyzing that sex specifically. I think race might be a more interesting issue, okay, if anything.
Okay. Do you know any of the SNPs specifically? I'm just curious that actually promote the poor metabolizing.
Yeah, so the big one for the poor metabolizer one is called STAR7. That's just the name of the allele. It's actually technically not a SNP. It's just an extra repeat in the TATA box. So normally it's 6 repeats. The poor metabolizer one, or the main one, is 7 repeats, and that extra repeat correlates to 70% decreased function. And then there's other ones. There's one that has 1 less TA repeat, and that's associated with increased function. And then there are other alleles as well.
How did you is the dose reduction recommended to be by 30%? How was that number arrived at?
based on the enzyme, like the degree of enzyme function it has compared to the wild type. So it's 70% decrease. I forget how exactly they got to that 30%, but is it something to do with that, Dr. Hader?
Please introduce the microphone. Thank you.
It's through PK studies. So we look at what is the concentration of the active enzyme, so the SN38, and that gives us an idea of how much to dose reduce. So you correlate both.
Okay, there's a nice bunch of talks, and we have more tomorrow for those of you who can return. And let's get your lab group down for a picture. Thank you.
Thank you.